Everyone. Moving on to the next lecture, that's a guest lecture on renal involvement in vasculitis. May I call upon Dr. Lakmal Vithanage and Dr. Chamila Dalpadatu to call upon the chairperson on stage. Thank you.
Good evening, everyone. I'm Dr. Chamila Dalpadatu, and I would like to introduce my co-chair, Dr. Lakmal Vithanage, to this guest lecture. We are very honored to have a very renowned speaker, Dr. Mukunda P. Kafle, from all the way from Nepal. He's a consultant nephrologist. He's an MD in internal medicine and DM in nephrology. From Tribhuvan University, Kathmandu, and he's working in the teaching hospital, Kathmandu. Over to you, Dr. Kafle.
Thank you, ma'am. So, it is a great privilege to be in Sri Lanka for the first time in my life, a very beautiful country. Thank you very much, Dr. Kumudini, Dr. Suranga, and all the Sri Lanka College of Internal Medicine team for having me here. I have been very highly interested in the academic session since this morning, and it's very well organized conference. I would like to thank everyone for having such a nice conference and congratulate everybody. So the topic given to me is the kidney involvement in cases of vasculitis, so which is in itself a very huge topic, and I'm trying to do as much justice as possible in the next 18 minutes or so. And please, I would like to acknowledge if there are some busy slides. I would like to apologize in the beginning. To start with some definitions. So vasculitis is inflammation of the blood vessels, arteritis is inflammation of the arteries, and capillaritis is the inflammation of the capillaries, and angiitis is the inflammation of arteries, so small arteries, capillaries, veins, so both sides of the circulation. So when it comes to the vasculitis, we are talking about, we are classifying these vasculitis into various level of the vessel size. So there are some large arteries in our body, some medium-sized arteries, and some small arteries, which has been classified in the literature. There are small vessels, or smaller than the small arteries. So some small and large vessel vasculitis can involve the medium-sized vessels, but large and medium-sized vessel vasculitis, they rarely involve the small-sized vessels. So small vessel vasculitis is very important when it comes to the kidney manifestations of vasculitis. So going to the Chapel Hill classification of vasculitis, there are 7 classes of vasculitis. The first and the foremost thing is that the vasculitis is classified according to the size of the vessels, so large vessel, medium vessel, small vessel vasculitis. So other variable vessel vasculitis and other types of vasculitis are less commonly encountered. So so in the next few minutes, so we'll be talking about some vasculitis in the according to the size of the blood vessels. So if we look at the arterial supply of the kidney is supplied by the renal artery, so the main renal artery gradually dividing into smaller branches. So kidneys can be involved in all the types of vasculitis, starting from the large vessel, medium vessel, or the small vessel vasculitis. So how do they involve, how do the vasculitis happen? So maybe there is some direct inflammation because of the microorganisms affecting the blood vessels straight away, or there may be some immunological injuries, or maybe some unknown mechanisms. So immunological injuries are the main topic for discussion this afternoon. So when we talk about renal involvement in vasculitis, what is the hallmark of renal involvement is renal dysfunction. So renal dysfunction can occur because of glomerulonephritis or tubular inflammation or the interstitial inflammation or these compartments in the kidney involved in one way or another. And there are very, very little examples of medullary angiitis or papillary necrosis in cases of vasculitis. So in the pathogenesis, glomerulitis is the inflammation of the glomeruli, tubulitis is the inflammation of the tubules, and interstitial inflammation, these are the three compartments that where the inflammations can occur. So in the glomeruli, there are different mechanisms of injury, and in tubules, although we say that there is acute tubular necrosis, actually there is little necrosis in vasculitis and there is more of tubulitis or inflammation of the tubules. So if there is blood in the tubules seen in the pathological specimens, if there is blood seen in the tubules, then it is vasculitis. Even though there is no features in the glomeruli, we should go back and look for the causes of vasculitis. So if we look at these small vessel vasculitis, there are three major things that happen in the pathogenesis. So either there is a direct attack of the antibodies into the blood, into the tissue structure, like in anti-glomerular basement membrane disease, where there is antigen in the glomerular basement membrane and it is attacked by some antibodies. Or there is an immune complex which forms somewhere else in the body, like in cases of HSP, there is antigen and antibody forming an immune complex somewhere in the body, say maybe in the throat or other parts of the body, and then that comes and attacks the blood vessels, so immune complex localization. Or there is none of these above mechanisms, and they are serologically identified as ANCA-associated vasculitis. So these are the main pathological mechanisms, and every small vessel vasculitis are the hallmark of the inflammation is the necrosis that happens in the kidney, in the glomeruli. And with necrosis, if there are granulomas, then it is granulomatous disease. If there are no granulomas, so like in microscopic polyangiitis, no granulomas. If there is asthma and granuloma, then that is EGPA or eosinophilic Churg-Strauss syndrome. Or if there is no asthma and only granuloma, then maybe it is a GPA. So again, the same thing. So the kidneys involved in a variety of vasculitis syndromes because of by the virtue of the vessel circulation in the organ. So let us come down now to direct antibody attack, immune-mediated vasculitis, and ANCA-associated vasculitis. So these are the small vessel vasculitis syndromes. So we now know that there are three mechanisms of small vessel injury. So either there is a direct antibody formed against the antigen in the kidneys, or there is immune complex formed somewhere else, or there is none of the above mechanisms and serologically identified as ANCA positivity. So anti-glomerular basement membrane disease is the direct antibody attack mechanism. So there is antigen in the kidneys or antigen in the, say, alveoli. So the same antigen found in the two organs, so there will be a good, what we call as a good pasture syndrome, anti-GBM disease, manifesting as alveolitis, glomerulitis, or one or both of them. So in the immune complex mediated disease, like that happens in cryoglobulinemia or in HSP or IgA vasculitis, there is antigen and antibody complex formed somewhere else in the body, comes to the kidney, deposits somewhere, and it is an immune globulin or complement deposit in the vessel wall of the small vessels when they pass through the small vessels. So glomerulitis, glomerulonephritis is often present, and so if there is a medium-sized artery involvement, it is less likely to be immune complex mediated disease. However, in cases of ANCA-associated vasculitis, there is neither a direct injury nor there is immune complex deposition. However, there is a necrosis. So it is necrotizing vasculitis, and when we biopsy the kidney, we will find some necrosis. This is because of the ANCA antibodies that are injuring in the glomeruli. However, in case of medium vessel vasculitis like polyarteritis nodosa, there is necrosis, but there is less granuloma, and ANCA positivity is not there. So if we look at the clinical features tend to be non-specific clinical features like constitutional symptoms that happen with other diseases also. There may be some renal features. So if we want to focus in the renal involvement, then this is the RPGN, or rapidly progressing glomerulonephritis. So rapidly progressive glomerulonephritis. And rapidly progressive glomerulonephritis more common with Wegener's granulomatosis or GPA and MPA or microscopic polyangiitis, and less with Churg-Strauss syndrome or eosinophilic granulomatosis polyangiitis. And cutaneous features may be present in vasculitis, mainly the immune complex related diseases. There may be some respiratory features. As I said, pulmonary renal syndrome is very common. So pulmonary hemorrhage very commonly associated in antiglomerular basement membrane disease like good pasture. There may be some nervous system involvement, like one of the most prominent clinical features of polyarteritis nodosa, where there is a peripheral neuropathy or mononeuritis multiplex, more in the medium vessel vasculitis. And there may be GI symptoms. As I said, in PAN, there may be very common GI symptoms may be common. In HSP also GI symptoms may be common because of involvement of the blood vessels in and around the viscera. So if we come to the physical examination, what are the specific physical examination findings in these patients? So there may be palpable purpura. There may be blood pressure discrepancies. There is a different blood pressure in one arm and a different blood pressure in the another arm. There may be neurological findings which we should not miss, and we should examine neurological tests. We have to do all the neurological tests. More specifically, the vascular examination in these cases of vasculitis, by the name goes vasculitis, so blood vessel examination is a must, so peripheral pulses have to be examined, and palpation for pulses in multiple areas, and auscultation for bruise in the subclavian, carotid, and renal and femoral arteries. So, as we already said, immune complex mediated vasculitis will manifest as purpura and abdominal pain and nephritis, like in HSP. And if there are more, so HSP is more common in the children, and renal. Before the renal failure occurs, there is isolated hematuria, proteinuria, and abdominal symptoms in HSP. So one very important example of immune complex mediated disease. In ANCA-associated vasculitis, as I said, there are necrosis. So the clinical features are of microscopic polyangiitis, GPA and eGPA. So clinical features include constitutional symptoms, prodromal symptoms, and ENT symptoms. And if there is a pulmonary renal syndrome, then this is very likely to be some ANCA-associated vasculitis. And apart from that, there is a list of clinical symptoms that can happen in these conditions. So kidneys can be involved as a part of multi-system involvement or single organ involvement. So if it is single organ involvement, we call it a renal limited ANCA-associated vasculitis. So renal limited ANCA-associated vasculitis can be diagnosed only by a kidney biopsy. So let us say MPA and GPA. So MPA, both angiitis. So as we said, angiitis, both sides of the blood vessels. So both are necrotizing, both are ANCA positive. So granulomas are very uncommon in MPA, and granulomas are more common in GPA. As the name goes, granulomatosis with polyangiitis. So there are more granulomas in GPA, and both are ANCA positive vasculitis. So in these ANCA vasculitis, there may be sinonasal disease or the upper respiratory disease, mainly in the eGPA. So these are, when there is a recurrent sinonasal disease, then we have to consider the ANCA-associated vasculitis in any case where there is a lot of sinonasal symptoms. So in interest of time, I'm going to skip these medium cell vasculitis and large vessel vasculitis, which are rarely manifest as intrarenal disease, and there are, say, renal vascular hypertension in cases of Takayasu arteritis. Otherwise, giant cell arteritis and other large and medium vessel vasculitis are rarely encountered in renal clinics. So let us talk about investigations. So laboratory tests are important to identify the type of vasculitis, the degree of organ involvement, and to look for the differential diagnosis. So routine blood tests to look for the say CBC, ESR, CRP, the markers of inflammation, blood culture, so serologies for viral hepatitis. So these are the routine tests. For more specifically, we do the ANCA test or the IgG antibodies, which are very specific for ANCA-associated vasculitis. And presence of ANCA directed against either PR3 or MPO. So these are diagnostic for ANCA-associated vasculitis. So other tests, we can do a lot of tests to rule out other diseases in all these vasculitic syndromes. So what are the diagnostic features? So post-immune ANCA-associated vasculitis, Wegener's, microscopic polyangiitis, Churg-Strauss, renal limited. All these are small vessel vasculitis causing necrotizing glomerulitis, necrotizing crescentic glomerulitis in the kidney biopsies. And other are showing glomerular nephritis and non-glomerular manifestations in other vasculitis syndromes. So, small vessel vasculitis, necrotizing vasculitis, and medium vessel vasculitis also necrotizing, but small vessel vasculitis more manifesting as glomerular nephritis. So, let us talk about kidney biopsy. In small vessel vasculitis, glomerular nephritis is by far the most common manifestation, vasculitic lesion, because glomeruli are capillaries. So these are the small vessels. So small vessel vasculitis, glomerular nephritis is the common thing. Medial vessel vasculitis, there is necrosis, but there may not be glomerular nephritis. If there is glomerular nephritis, it is small vessel vasculitis. Large vessel vasculitis, manifesting as renal vascular hypertension. And if you do a kidney biopsy, there is ischemia and no more glomerular lesions in these large vessel vasculitis. So the approach to treatment of vasculitis is there are three phases of treatment: induction of remission and maintenance of remission and monitoring. So induction of remission is when the disease is very, very active. We hit the disease very hard. So we give high dose glucocorticoids with or without other immunosuppression, but without other immunosuppression, it's very difficult to get control of these diseases. So what we do is we give high dose glucocorticoids and then cyclophosphamide or other immunosuppression. So high dose glucocorticoid, methylprednisolone for 3 days intravenous, followed by oral prednisolone 1 milligram per kilo, and then we gradually taper it down. Cyclophosphamide may be given as oral or IV. IV is more preferred nowadays because IV cyclophosphamide is it reduces the total total dose burden of cyclophosphamide in the body. And newer drugs like rituximab are tried. Rituximab given as 375 milligram per meter square for 4 doses with prednisolone, or so rituximab followed by cyclo. It depends upon which research study we follow. Other mode of treatment may be plasma exchange. So we do the plasma exchange for 2 major indications: if there is a life-threatening pulmonary hemorrhage, whether or not there is a kidney disease, and we do when there is a dialysis-dependent renal failure at presentation. So we might take the patient for plasma exchange. Other strategies for maintenance therapy for treatment of these small vessel vasculitis is oral cyclophosphamide, oral azathioprine, mycophenolate mofetil, methotrexate, rituximab. So these are the various maintenance strategies. It is more it is better done at the clinics of the specialists as compared to non-specialists, because it involves a lot of immunosuppression, a lot of risks of immunosuppression. So it is better that it is done at the clinics of the specialists. So there may be relapse. There are a lot of relapses. So diagnosis of relapse is done by the clinical and pathological evidence of recurrent disease. So increasing titers of PR3 or MPO doesn't say that it is relapsed. It can predict relapse in some cases. So when these titers of PR3 or MPO start increasing, there is some strategies. Some researchers use the strategy of preemptive strategy to treat with immunosuppression. Otherwise, when there are clinical features of relapse, then the immunosuppression, just like we just discussed, there is the phase of induction of remission and maintenance of remission is suggested. So in the modern day practice, rituximab may be the best treatment for relapses of vasculitis, renal manifestations of vasculitis. So I'm going to skip this large vessel vasculitis. So let us go to the last slide of the day. So of this session, kidneys are frequently affected by systemic vasculitis, because the kidneys are very vascular and the blood vessels keep on changing the size. So all the blood vessels, all the types of vasculitis can affect. They are most often involved in small vessel vasculitis. MPA and GPA are associated with and may be caused by ANCA antibodies. There may be necrotizing medial vessel vasculitis, which do not usually cause glomerulonephritis, and large vessel vasculitis mainly cause renovascular hypertension in these patients. These are my references. There are some notable research findings in various research trials, which the interested learner can go back and involve in. So I bring my regards from Kathmandu, Nepal. So Society of Internal Medicine of Nepal is going to have its conference in 1st and 2nd December, exactly less than a month from this date. So interested people can visit the beautiful country of Nepal. And I thank you for patient listening, and I congratulate the Sri Lanka College for such a huge participating audience, and I look forward to a similar type of audience in my conference, hopefully. Thank you.
Right. Thank you very much, Dr. Mukunda Kafle. And it's a complex topic, but I think a comprehensive talk on including every aspect. So it's time for a question or two.
Dr. Kafle,
Yes, ma'am.
may I ask a question? What
Please.
are the chances of recurrence of vasculitis after transplant?
Yeah, so thank you very much for this great question. Actually, these vasculitis syndromes, they can recur, and there may be de novo vasculitis even after transplantation, but it is not a very common phenomenon because we are using multiple immunosuppressive drugs in a patient with kidney transplantation. So we talked about the different phases of treatment like induction, maintenance and monitoring. So our patients in kidney transplantation, they are always taking cyclosporin or tacrolimus or other CNI inhibitors or mycophenolate mofetil and steroid. So it is very less likely that they will recur, but if they recur, it is very difficult to treat because they are most likely resistant to all these armamentarium of drugs that we have in our stock.
Thank you very much.
Thank you, ma'am.
So in the interest of time, we would like to conclude, and I would like to invite Dr. Lakmal Vithanage to hand over the certificate of appreciation to Dr. Kafle. Thank you very much.
Thank you very much.